Today we're going to be talking about Wellens. Now, let me start with the story of this patient I will never forget. She was in her mid-30s and she came in, the other day with chest pain. So she did have chest pain that was crushing. She'd had the pain the night before, and it was very distressing, and her husband insisted that even though the chest pain had resolved, she needed to come back, come to the hospital anyways. And she was completely fine, smiling, talking, ready to leave. A repeat ECG prints out and everybody relaxes, but there was something in her ECG that did not make me want to sign her off, especially because, fine, our drops came back just barely elevated. But the ECG did make me stop, and I'm just going to show you that ECG right now. So this was what the ECG looked like. And as you may observe, something is going on in V1, in V2, and in V3. Now, these T waves are not normal. They are bent as if someone is trying to, pinch them down, press them down. I'm sure that we can appreciate that there is no ST wave elevation, ST segment elevation. If you draw your line across your J point, this, and especially if you use your ECG ruler, you're going to find out there's no ST elevation here. So there was no ST elevation, drops were fine. There was that pressure, saying, why are you keeping this lady here? There's no chest pain today, Worst case scenario, refer her to rapid chest pain clinic. They will see her within 2 weeks. But, I'd seen this pattern before. So let's talk about why we are worried. We are worried because this is typical for the left anterior descending artery whispering really, saying I'm about to close. And if you miss it, this can turn into a full anterior MI, right? And also you can see V4 as well. V4 is also showing you that pattern, although I'm going to show you the two types of Wellens, and then we can decide which type this is. But let's talk about the left anterior descending artery. Now, as you can observe here, the left, the heart is supplied by two main arteries. Let's use the blue marker so that this is much better. So you can see the heart is surrounded by two main arteries, the left anterior the left coronary artery, which sometimes is referred to as the left main coronary artery, and then the right main coronary artery or right coronary artery. And the left coronary artery branches off to the circumflex artery, which you can see kind of wraps around into the side of the heart. And then the left anterior descending artery here, which is our main character of the day, is what branches off into the diagonal arteries, and it supplies the whole front of the heart, the anterior aspect of the heart. So the circumflex feeds the side of the heart, but the left anterior descending, which is LAD, which we refer to as that, is what supplies the muscle of the heart, and it's the muscle that does the majority of the pumping. Right? It also supplies the front part of the septum of the heart and the apex. As you can see, this is the apex of the heart. So if the LAD is struggling, this is your blood vessel here. If there's like plaques, right? If there are plaques here, this is like fat. I should have used yellow. So if there are plaques here, right? And there's now a blood clot forming here. Let's try and use another. So if this is the blood vessel and there's plaques of fat here, and which has resulted in a clot forming such that blood supply cannot access the anterior aspect of the heart or the septum or the apex, what you're finding out is that, there's no blood supply there. And sometimes the clot can be transient in the fact that it's getting bigger or a little blood is seeping across. And that's why you might have intermittent chest pain or tightness of the chest or tightness of the heart, because maybe the clot is small and possibly still getting bigger, or the clot is, is transient, passing through. Sometimes it passes through and there's reperfusion of the heart. But let's transition it into the ECG findings. When the left anterior descending artery is 80 to 90% narrowed, the front wall gets enough blood just to keep it going, but not enough to be happy. So instead of ST elevation, the T wave changes shape, and they show the shadow of ischemia, the kind that comes before a massive heart attack. And that shadow is what we call Wellens syndrome. Now, there are two types of Wellens, and if you learn them once, you will spot them forever. Type A is what I am drawing here as the biphasic. Biphasic T waves. Now, this is just in 25% of cases, right? So you see here that the T wave goes slightly up and then down. Slightly up and then down. It's much more pronounced. That pattern is much more pronounced here in V2. It looks gentle, almost harmless, and in a pain-free patient, you're tempted to send them home. But this is a red flag. Type B is much more of deep inverted symmetric T wave. So this here would show you the difference between type A. As you can see, the type A is biphasic. In type B, it is deeply inverted. It is symmetrical. So you don't have one going this way. It is symmetrical, right? And it is deep, it is sharp, it's like an upside down ice cream cone in V2 and V3. This tells you that the left anterior descending artery is critically narrowed right before it blocks completely. So why does it matter? Now remember the anatomy we drew, in this diagram. The LAD supplies the entire front wall. So if it closes the biggest and strongest part of the heart, which is the anterior chest wall, which contains the muscle that pumps the heart dies. And that's why Wellens is so dangerous. That is why you should not miss one. It's the ECG that warns you before they crash. So Wellens is not subtle. It's the heart quietly crying for help. And once you know the signs, you will never ignore those T waves again. So I hope this was helpful to you to at least gain an understanding of Wellens syndrome and why there's so much fuss about it. It can be rare, but the fuss is the fact that the patient sometimes may not be clinically presenting in the way that a heart attack presents. It's your duty to fish out either a biphasic T wave or a deeply inverted symmetric T wave, especially in V2 to V4, and then warn the cath lab. Let me know if you found this video helpful. I'll see you in the next one.